Our conversation takes us, and it would form a number of things. A current conversation that's happening in Kenya, as well as our Healthy Friday conversation for this morning. The Member of Parliament for Endebess is Dr. Pukose, and he is here with us this hour. He also sits as the chair of the Health Committee of the National Assembly. Good morning.
Good morning to you.
How are you?
Good morning to our listeners.
Good morning.
How are you doing?
I'm doing well.
Karibu sana. Good to have you here again. Many issues up for attention when we look at healthcare in the country and what is currently, taking everybody by storm. But before we get into that, we want to welcome you with today's proverb. CT will give you the proverb, and maybe you can interpret that for us, and then tell us what you think about it.
Our proverbs for the whole of this week have been from the Republic of Niger. Earlier on, we were asking ourselves, people who come from Nigeria are called Nigerians. People who come from Kenya are called Kenyans.
Yeah.
Come from Uganda, you're called?
Ugandans.
Okay, so if you come from Niger, what are you called?
Nigerian.
Nigerian.
Yes.
Nigerian.
Yes.
A-I-N-E at the end.
No A.
There's no A?
No.
It's Niger. So it's Nigerian.
So it's Nigerien. If
you put an A, it's Nigeria.
Nigerian for Nigeria.
Exactly.
Yeah.
The so Nigerian for Niger.
Exactly.
Very good. See, now I've got it. I'm a bit slow sometimes.
It needed one Dr. Robert Pukose to come in.
But I get it. I've now got it.
Okay.
Now the proverb. No matter how good you are to a goat, it will still eat your yam. No matter how good you are to a goat, dress it up, give it a hat, it will still eat your yam.
To translate it means that, literally when you look at it, it means the food for the goats is a yam.
Mm-hmm. It is.
So it doesn't matter what you give it else that is not food for it, then it has to eat the yam.
Oh. Nice.
The goat knows what it likes. It knows what is good for you. Can just go around thinking you're going to give the goat fish.
Whatever you give it. Very nice.
That's great. Great to look at. So, Dr. Pukose, we're going into. You straddle the Member of Parliament for Endebess, but also in the committees, the chair of the Health Committee of the National Assembly.
Yes.
And that forms information for us as we have this conversation this morning. Over the last few weeks, there has been furor in terms of what's happening with healthcare in the country. And this is taking on different personas, whereby folks are able or not able to access what they need in terms of payment when they go to hospital. And I've said that when you have shirts going through a factory, through the chain, that if you see one shirt that doesn't have a button, the rest of the shirt is fine, but there's not one button. What is it called? It's called a reject. So the shirt in its entirety is not working. It is removed.
Yes.
So you can't say that this shirt is kind of okay. No, it doesn't meet the mark. So you're not going to put it with the rest in terms of those that are working. So if some people can access health care in terms of payment and some people can't, then we say that the thing as we look at it is not working and that there's a problem here. If we look at another aspect of it, just yesterday, we've seen that doctors are going to tell us, well, you know what, we are not going to do this. We're going to go on strike. If you can more than halve the amount of money that is going to be paid to intern doctors, then we have a problem. So it looks as though there are many different aspects of the healthcare system in the country that seem to be hobbling at best. And our question very simply is, what's going on?
Thank you. The analogy which you've given does not apply in health, unfortunately, because when somebody is sick, do you treat that person or you say that person be allowed to die? Yeah, because that looks like somebody who has just a shot with one pattern which is not working, and therefore somebody is admitted to the hospital. He is sick. It is a process. Healing is a process.
Yeah.
And therefore, healthcare should also be seen as a process. It is not a one-off thing that you can fix it and it just works that way. So there are several factors when it comes to healthcare. You are talking of health products and technologies. You are talking of the human resource. You are talking of the what kind of infrastructure you put in place. The Kenyan healthcare system, the first call of majority of Kenyans is the public institutions. 65% go to public institutions for their treatment. And therefore, if we get right what is ailing our public sector, then we should be able to fix our healthcare system. And that is what the government has tried. It has been a process, even when we got independence, our founding fathers, they mentioned three things: education, health, and poverty as critical issues. And we've been trying to fix all these things since independence. And therefore, you cannot just now say that with the new developments that have come into place, then the government is failing. No, it's not true. When you look at our healthcare system as we speak today, when this government came into place, they realized that governments that have been there have been trying to fix the system. But without laws in place, then things will not be able to work. So they identified 4 laws. Former President Mwai Kibaki, when he was the Minister for Health, he introduced what we call Facility Improvement Fund. This Facility Improvement Fund, subsequently, as time went by, it was scrapped when we moved into devolution. But counties like Makueni, under Professor Kifuta Kibwana, they developed that, and they realized that this was something that was good, and we should be able to get it back. Under the Kenya Kwanza administration, they came up with 4 laws. One of them is the FIF law. The second one is the digital health law, social health insurance law, and the primary health care law. All these laws have come into play to try and fix our healthcare system. Now, as we do our budgeting, because that is where now Parliament comes in. In the first place when we came in, we had post-COVID, which had brought down healthcare all over the world, had brought down economies all over the world. So the first thing was, how do we start from where COVID left us? Then subsequently, as we came up with these laws, one of the areas that had been severely abused was the NHIF. Because even when you look at the NHIF, when audit was done in terms of the number of people who are registered, NHIF initially had about 12 million registered clients. But when this was connected to the Kenya National Registration Bureau, out of that 12 million, about 3 million were found not to coexist. And yet, we've been paying money for these people. They've been going to the hospitals, they've been treated, and claims have been put. 3 million Kenyans who don't exist. So, with this now system of fixing that, it means after cleaning up, you have about 9 million who have been transitioned into the social health authority. Okay? Plus the other ones now who have been registered. But unfortunately, you'll find that only 4 million of these are people who have formal employment. Now, the next step that the social health authority needs to move into is how do you bring those who are in the informal sector to contribute. But at the same time, what has happened is that in our budgeting system, we've put money for emergency, critical, and chronic illness fund.
Yes.
Which was in the current budget for this financial year, 2.1 billion. Then we put money in our primary healthcare fund, which is 4 billion. When we started this rolling down this program in October, up to January, for the emergency, chronic and critical illness fund, what has been operationalized is when a patient gets a severe injury or gets a heart failure, heart attack, or even head trauma or stroke. This patient is taken to the hospital, and once the patient is taken to the hospital, stabilization, resuscitation and stabilization is done.
Yeah.
And within that 24 hours, hospitals are supposed to make claims. From the emergency, critical and chronic illness fund, the claims that have come into SHA is only 21 million out of the 2.1 billion.
Okay.
So meaning the money is still there.
Is it though?
Yes.
Because we did hear that, we did hear directly from the Director of Health, Dr. Amoth, that they needed more, and because this is now critical illness that is taken care of by SHA. But if you look at the other levels, it was very clear that they needed more people to enter into the system in order to then be able to offer the care. So it seems that on that end then, that there is a problem, that there's not enough funds, because the more people come in and pay premiums, that's now we use that money to take care of it at that level.
No, for this emergency, chronic and critical illness, it is not the contribution.
No,
this is exchequer funded.
I understand that.
So when what the exchequer has funded is 2 billion.
I understand.
But what the Kenyans have utilized or the claims that have come from hospitals is only 21 million.
Yes.
Look at the primary health care fund. Up to now, the claims that have been paid is 1.3 billion out of the 4 billion. Yeah? Meaning we still have money there that can take us up to the close of the financial year. But what has the government also done? Because maybe now as Kenyans embrace this, because initially we've had people resisting. And the resistance that is coming mainly is not even from the public facilities. The biggest resistance is from the private healthcare providers.
Okay.
And that is why they have even gone further into this week and they're trying to issue a strike that if we are not paid the money that is
30 billion, 30 billion in arrears. They claim 30 million in arrears.
That 30 billion, unfortunately, is not owed to only private hospitals.
Okay.
That 30 billion, out of that 30 billion that is owed, you have close to almost 25 billion, which is owed from the government.
I'm sorry, please clarify that.
You have 30 billion.
Okay.
Out of this 30 billion, you have government institutions that have made that are owed by SHA, by NHIF. These government institutions like Moi Teaching and Referral, which is owed about 1.7 billion. Kenyatta National Hospital is owed about almost 2 billion. Kenyatta Teaching Referral Research Hospital is owed about almost 1.5 billion. So it is not only private hospitals. And again, even this money, when you look at what is owed to NHIF, you have government institutions. We have WIPA, the Workman's Compensation.
Yes.
That it was being administered by NHIF with co-insurance that was sourced. The Ministry of Public Works, the Ministry of Public Service, the public service or public service workers, they have not remitted that money to NHIF so that NHIF can pay for those services.
NHIF at that time.
Pardon?
NHIF at that time.
NHIF at that time.
Okay.
Yeah, because this is money which is supposed to come from Treasury. Go to NHIF, then NHIF can pay.
So let me ask you then, why doesn't that money leave Treasury and go to pay the bills that it's supposed to pay? Let's just say that 5 billion shillings is what is owed to private hospitals. So if somebody walks into a private hospital today and is trying to get treatment and they say, well, we're not able to offer 1, 2, 3 because, we don't have a bill paid, could be the scenario. But what's the reason why these monies are not being paid to the facilities that they're owed?
And just to add, what they're arguing then, that the decisions that have been made this far is because of months of failed engagements, unfulfilled promises, and growing financial distress. So there are certain arrangements that are being made, conversations that are not being honored. That's according to those who are, sharing their grievances.
That might be the case. because you have government obligations, maybe paying debts and all that. But gradually, the government has been paying. From the information we get it from NHIF and the ministry. They've been paying. They might not have paid all the amount that is outstanding.
Is it realistic? Is it realistic what is being paid to be able to handle what has to be handled at the time? Because this is a matter of life and death.
It is realistic.
Okay.
But what I also want to add is that from these other services which they are providing, because now under the new scheme of SHA, we have money that is coming from SHIF. There is no as when we made the SHA during the budget policy statement 2 days ago. That is on today is Friday. That is on Wednesday. They told us that there is all the claims that are of services which have been rendered as per for SHIF. There's all of them are being processed and there is no outstanding. For primary health care, they've paid 1.3 billion and all that is coming is being processed. Then for emergency, chronic and critical illness, they paid 21 million because that is what has been claimed. And they still have more than 1 billion in their account. If services are offered, then they should be able to claim. In the current supplementary budget, because we are saying, should the services be absorbed, then we also, maybe this money might not be enough. Because the way government does budgeting is that you do an annual budget. Then after the annual budget, under the unforeseen circumstances, then you can do a supplementary. Supplementary 1 was done. We are now in the process. Supplementary 2 has been tabled in Parliament. And we'll be discussing it on this week on Thursday.
Next week?
Next week on Thursday. So under supplementary budget 2, we've provided money for emergency, chronic and critical illness. We've provided money for primary health care fund. People, for SHIF, there are contributions which people are making. And for any service that is being offered, then that is being paid. As far as the bending bills on NHIF, the committee is having a retreat next weekend on Friday and Saturday. We want NHIF to present to us all the bending bills. And we wanted them to divide these bending bills into public and government and public and private. Once they've divided into private, we also want to look at how long have these bills been bending, because they must give a date. This amount of money is bending, and this is when they are paid. Because unfortunately, we realize that public facilities are not being paid promptly. It is only private facilities that are being paid promptly. Yet, majority of Kenyans, 65%, are going to public. What I also want to add is that what the government has also realized is that we have challenges in terms of county facilities, where county hospitals, that is the level 2 and level 3, are not providing adequate service because of funding. They do not have enough drugs, they do not have enough equipment, and they do not have enough personnel. So what has the national government done? The national government has negotiated with the World Bank, and the World Bank has given us a grant. And in this grant, we are going to give, they are going to give the initial health products and technologies to all our level 2 and level 3. They are also going to equip all level 2 and level 3. Then now that they have their, then we'll also be able, what the county governments have also delayed in paying back KEMSA. And because of this delay in paying back KEMSA, and this they have attributed to delays in disbursements from the national government on county revenue. Now, that the counties are not getting their money in time, so that is the reason why they have explained that they are not able to meet their obligations for KEMSA. And this is making KEMSA not to be able to provide medication in time. such that you have stockouts within the counties. Now, with this support from the World Bank, we also, as the national government, we are going to recapitalize KEMSA with about 2 billion. Yeah, and under the current supplementary 2, we've provided 1.5 billion. This is going to recapitalize KEMSA, so that KEMSA now will have enough medication when the level 6, level 5, and some of level 4 makes their orders now, then there's enough medication for them to be able to disperse.
Right.
And then they can now be able to also take time now to recover their money from the county governments.
Okay.
And then when we provide, under this World Bank program, once the health center, that is dispensary and health centers, and some of level 4 facilities are provided with health products and technologies, with equipment and even support in terms of training. Then what it means is that our public health facilities will now be maximally operational.
Okay.
And because they have the FIF account, then whatever they generate, they can be able to
it goes back into the hospital essentially, or back into the facility,
and be able to provide services.
Are we comfortable with the way the system is currently? So is it working as it was envisioned to, from when it was launched? And we're talking now about Taifa Care, and then hoping that it can improve, or are we comfortable the way in which it's being delivered?
That's a very difficult question to say, because you know, when from where I sit as a doctor, you might find that you have people who have gone to a health facility and being sick and expecting to get services, and you are not able to get the services you expected. So to say that you are comfortable, that person will not be comfortable, because he went to a health facility and did not get the services.
Exactly.
What is happening is that we have teething problems within the implementation of this program. And one of the biggest challenges is information. SHA has not done well in terms of informing the public on what is the package. You know, like now when you speak about Jubilee, you are giving that this is the package that Jubilee is giving for outpatient, for inpatient, and that kind of thing. SHA has not done well in terms of disseminating the knowledge to the public, so that the public are aware that when I go to level 2 facility, this is what I expect. When I go to level 3 facility, this is what I expect. And then, and also, in terms of bringing those who are in the informal sector into registering and paying, so that you find that somebody who is in the informal sector will only want to register for the program for SHA or SHIF when he is sick or the relative is sick. Yeah, that is when they want to register, not realizing that you don't have to wait to be sick to register, because like just the way we take insurance of our vehicles, you don't wait to knock somebody's car so that you take the insurance. You put on your insurance and continue driving and drive safely to make sure that the road is safe for everybody. Yeah. And therefore, even for us in healthcare, you don't wish to be sick. Nobody wishes to be sick. Nobody wants to be sick. But it is important that we pay our premiums. You take the insurance, and therefore, even people who are in the informal sector, it's important that you make your contribution to SHA. And when it comes to even providing the correct information, because we are doing the means testing, please provide the correct information. Don't cheat, because you will find that people who are even able are now lying not to, so that you pay less. It's not right. Yeah.
All right.
Pay what you really can afford. Then let those who are not able to pay be paid for even by the government, so that because we have indigents who cannot be able to afford, and the government has a provision that those who are not able to pay, the government will pay for them, and that way we can be able to provide health care for everybody.
Allow me to interrogate.
Yes.
No, go ahead.
Yeah, because he's talked about the role of the patient and the government, and this major point of contention, maybe just for clarity, and we're glad that you're here so I could engage you in the SHA's outpatient reimbursement. The doctors are claiming that, like the word I used, unrealistic, that the government would, for every patient in a month, pay 75 shillings. Is it 75 shillings, Dr. for every patient monthly for this particular outpatient reimbursement, and as far as SHA is concerned?
The outpatient reimbursement is a capitation.
Okay.
So that when you are in level 2, level 3, level 4 facility, or up to even level 5, there is what we call the capitation. Capitation means you have clients who are attached to this facility.
Okay.
Yeah. And these clients are the ones who can choose to come into that facility through the mapping which they have done.
Yes.
They've done a mapping, and for facility, let's say facility A, they have allocated a certain number of patients. This number of patients, if they become sick, they can go to that facility.
Okay.
But the good thing with the current SHA system is that you don't have to limit yourself to only that facility. You can still seek because you can fall sick. If the facility which you are supposed to be, which you are capitated to,
okay,
is in Nairobi, and you fall sick in Mombasa, you can still go to Mombasa and you'll be treated. But now, when they give this capitation, it doesn't mean that all those people who have been capitated to this facility will be sick. Yeah.
But how much is it?
I wouldn't
per
be...
patient. Is it, I'm just want you to clarify, if it's the 75
I think
shillings.
It's 75 shillings per patient.
Per patient?
Yes.
Every month?
Every month. But not all those patients will be sick.
What I wanted to ask is this.
I don't know whether you understand how capitation works. Capitation is that if you have, let's say, facility, this is my facility, I'm the doctor for facility A. I've been allocated 1,000 clients.
Okay.
If all those 1,000 clients fall sick, then I'll treat all of them. But you'll find that out of the 1,000 that you've been given, maybe 20 or 50 might come for treatment. The rest might not come for treatment. Meaning that money that was to treat the other ones, that is not utilized.
Because they're arguing that you're putting these patients at risk, and the hospitals are now forced to cut down on some of their expenses, some medicines that are supposed to give them, and that it's a little lower than what is expected. Even though you're arguing that not all of them will get sick, but this is what the doctors are saying, especially the ones that have now said you owe them.
Maybe they're offering good service that many clients are flocking there.
Yeah,
and because and they expected maybe fewer clients to come.
It's the same. There is a discipline called actuarism.
Yes.
When you pool resources, you figure out what it is that would be, perhaps in this case, a minimum that you need to contribute to that pool.
Yes.
It's the same principle of insurance.
Indeed. Not everybody's going to get sick or have an accident on the same day.
Yes. And if you say, for instance, the matatu industry, because of the way they go about their business, they were considered a very high risk for the insurance business.
Right.
The reason is because what they pay doesn't cater for the claims that they eventually have.
Yes.
So, again, doctors are talking about what they're experiencing.
Yes, what they're experiencing.
Yes, but there is a much larger picture to this. When these figures are arrived at, they are not random. No. Somebody goes into the process of thinking about it, and with a certain expectations and certain anticipation that a certain number of people will contribute to this. If that number doesn't contribute, and even the government, when they do that, they look at the figures and figure, why am I explaining government things?
It's a conversation.
But this knowledge is shared.
Yes, it's actually public knowledge.
Yes.
What I want to ask two questions. One, the health committee that you belong to, what exactly do you people do? What's your function?
The health committee works under our standing orders of parliament.
Yes.
And under standing order 216, we oversight the ministry and its sagas in terms of investigating what they are doing, looking at their programs. We can also, like now today, we're going to Kenyatta National Hospital, where a patient was apparently murdered in the hospital, in the ward. So we'll try and investigate what really happened, what systems failed this hospital that this is happening, and because a patient, you've taken your patient to a hospital and you expect that patient, the security must be provided.
Well, I mean, we're talking about a level 6 hospital.
Yes, a level 6 hospital. Yes.
Easily the largest one in the
Republic.
country.
Yes. So it should be of public concern to Kenyans. What happened? We also provide. We do the quarterly reports for the financial expenditure for our ministries. We also look at their budget, and when they present their budget to us, we can amend that budget, either reallocate some money to other where we think it's more needy than the other one, and that kind of thing.
You actually segued into what my second question was going to be. When you look at the budget for health, how much money do you allocate for communication?
It is the ministry that must be able to request. As we speak today, SHA requested for 350 million for communication, and they will be allocated. The ceiling for SHA for expenditure is 7%. Now, they cannot spend that 350 because they have other obligations at the same time. What we've advised them is that you can spend that 350 gradually.
Over what period of time?
Because you have to start. You have to stick to the limit, the ceiling of 7%.
Okay.
So they have to look for a formula. If you want to spend it over 3 months, then you don't have to get all the 350 at a go.
See, the reason I'm asking this question.
Yes.
The problems that we seem to have, not just with the health ministry, but with the very many government ministries, is this subject, touchy, prickly subject of communication.
Yes.
Okay? And a lot of the times when you dig and figure out, the budget allocation for communication is almost non-existent. If it exists,
it exists.
Yes, but statistically it's irrelevant. Because if you look at what needs to be done and then you look at the budget, you wonder, so how does this work exactly? What are they going to do with this? Because you have a ministry, the ministry is full of so many departments. The number of things they need to do. Okay, we're looking at SHA now.
But 350 million is not little money.
It is little money.
For communication?
For communication.
It is little money.
Okay.
It is very little money.
Especially since we're looking at issues when folks in Kenya today are complaining about SHA not working. It is hinged on communication, not necessarily the brick and mortar of what's happening within the system. We're not talking about will you get a bed and will you be treated and will you... No. We're talking about the issues that nobody told me I was supposed to go. Case in point, the gentleman who was in Mombasa and he went to Coast General Hospital and he was not supposed to actually report there for the issue that he had. Was he then told that he was supposed to then go to the hospital in Tuda, which was a level 3, to get something done? It was not a matter of will we treat you. It was a matter of you're in the wrong place because of 1, 2, 3. Now, if that information is being shared large scale, if everybody knows that in this case, if I have a headache and I want to see a doctor, I need to present myself to 1, 2, 3, or 4. Or if I have 1, 2, I can only go to 5 and 6 if I have been to 3 and 4 and I have been referred by a doctor. So what do people do? They go to Coast General. Somebody tells them, no, you're not supposed to be here because of 1, 2, 3. What do? They go home because they don't know. So the majority of the issues that we are seeing today are hinged on communication. That communication, which by your own admission has not happened.
Yeah.
So why not then really think about putting some serious grease behind making sure that people know what they need to know? Because if I don't get the information that I need, as far as I'm concerned, the thing is not working.
And, yes.
Yes,
Go ahead,
and
Ankey.
also it's not just communications to the common mwananchi,
Yes.
because there is a civilian, but even health practitioners or professionals, those people who are receiving the people. Some of them don't even have any idea how the system works. So who then is going to guide these systems to actually come to life? Because there's this point you go, and the person you'll hear a leader say, "Well, it is not a matter of the money's in there or you're in the wrong facility. The person attending to you, all right, did not have the information." Now, such things are really making this look like it is not working.
You are a medical doctor.
Yes.
One of the things that you are trained in, what you call bedside manners. I was trained as a teacher. And one of the things that we were taught when you're teaching is something we call set induction. Before you begin talking on a topic, I used to teach the English language.
Yes.
And you want to talk about vowels. You don't say, okay, today we're learning vowels. You have a discussion about vowels, and
Without
people participate without really realizing. Then you say, you see, as you talk about this is what we call vowels. And then people go, oh, okay?
Yeah.
Same. In medicine, you don't just go and say,
I'm going to chop
the way
off
I'm
your
looking
leg.
at you, you're likely going to die.
You can't say that. You must
There's a
give hope
process.
to the
Yes,
patient.
there's a process. There's a process that you follow, so that when the information arrives at the patient.
Yes.
I remember in the advent when HIV was a terror
yes.
disease, people had to be counseled on how it is you pass on that information,
Yes.
because you could see the problem. It is the same principle that I am saying when it comes to introducing a system that is new.
Yes.
Even as you work on it, as you plan, that journey needs to be walked. You need the public to walk with you. It's a journey. And you're going to be journeying for a long time. The public needs to walk with you throughout. And that walking is the communication that we're talking about.
Yes.
So that at every stage you've been told there's this. Do you know the time when we were changing our fiduciary issue? The notes, the central bank.
Yes.
Do you remember that communication?
Yes.
My friend, even if you didn't know, you would know.
Yes.
Step by step, and the days until the final day. And even after that, you're told, okay, if you've missed this, this is what you do. Something as critical as healthcare requires more details, concerted and consistent. That is really it. And since that committee has say as to how much money goes into it, the communication budget becomes critical, because when people know and understand, they even know that I can go to this place so that I can prevent this thing that could be a problem. I don't have to wait until it's almost falling off before I now go to this level. That would actually be a far more cost-effective way of getting the Kenyans to understand how to approach healthcare, as opposed to saying, I'm not sick enough to go to hospital. No. Understanding that healthcare doesn't have to do with you feeling unwell.
Yes.
Now, that's communication, Daktari. And you happen to be the chair of a committee that is crucial, absolutely pivotal in getting some of these things done.
Daktari, your meeting next week, Deputy President Kithure Kindiki has given his word and is given the health ministry officials until the end of this month, I'm looking at about 7 days, to resolve the SHA issues before launching a nationwide registration campaign. 7 days. 7 days, and it has to work. But you see, this thing was already, guys have been registering.
Yes.
And now, all of a sudden, at the heart of it, things are, neither here nor there. If I put it in the best way a common man should feel right now. And now here you have the second in command saying you have 7 days, put things in order.
7 days might not be achievable, because you, as you rightly put it, Muga here says it has to be continuous, consistent, and it has to be seen to be done. So I think maybe within that 7 days is for them to make sure that things are properly put in order.
But the Kenyans are getting sick within the 7 days.
We have to, this has to be a continuous process, to me,
sure.
the way I look at it. That we have to look and even audit ourselves, what is it that we are not doing rightly. And maybe now that when now you say 350 million is not is very little money, you are experts in communication, yeah. I'm a doctor. So I'm hearing from the experts, and that also gives me information in such a way that when they present now their budget and say, we want this much, then I will not say that is too much.
Some questions coming from, folks who are listening in on the show this morning, and one of them being, still going to the previous issue of why having moved from NHIF to SHA, that one of the big issues was the informal sector and how they've been captured here to ensure that they can then now go and get the medical care that they need. Not enough is being collected from the informal sector.
Yeah, no,
how is that going? And how is that going to be taken care of moving forward?
We've asked SHA to come up with a plan on how this can be done, and look at what is it that why and the reason is, why is the informal sector only paying when they are sick? Yeah, people need to pay continuously and contribute and realize the importance of this. But there must be something that will make these people to be able to contribute into this fund. And I think that is where issues of communication will come in. Issues of are there even any incentives for people to continuously contribute? Is there something that they can be able to do to motivate them such that they are able to pay?
Okay.
So I think for me, I don't have to, I'll not be able to, I'll still be asking the same questions to SHA.
So,
because,
So then looking at it still from an oversight role, because this is the seat that you straddle in the National Assembly, and that to push for oversight beyond the legislation where you say, okay, spend this money, representation where you say, okay, so what has happened for people here, is that to say, okay, there are different moving parts to the whole healthcare system. We can talk about the fund and we can talk about what ensures that you can go to hospital. Healthcare will cover you in terms of money and care. But then look at the other moving parts. Just the other day, yesterday, medical workers have said, you know what, this is not working. And from what we've been told, interns were going to earn a certain amount of money. That's been slashed by more than 50% to be enacted come July. How do you work? Because one of these moving parts is not going to allow this vehicle of healthcare move along. So if a one wheel is not there, you're not going to say a 4 or 3-wheeled vehicle unless it's tuk-tuk. But in this case, we're saying it's a 4-wheeled vehicle. It's supposed to be moving. One wheel, because healthcare workers are saying we have a problem. So the whole thing then doesn't move properly. How do you deal with those moving parts? Where does this oversight role say, okay, come on, ministry, you guys were supposed to have sorted this out. It's not working. How do you deal with issues like that?
Issues about salaries is an issue between the employer and the employee. And for this case in the public sector, we have the SRC that sets the salaries and allowances for every institution. The initial payment for interns was a negotiated figure. And at that time, it was based on the number of interns. When I went to medical school in 1990, we were in a class of 100. Then subsequently, the classes have increased. As we speak today, you'll find that you have a class of 500 to 600 students in one university. When we were 100 at University of Nairobi, the ones who are training at Moi University were 50, because Moi University was that time just starting. So they would not be able to be allowed to take more students. So in the whole country, we were about 150. Right now, you are talking of 3,000 students graduating, doctors graduating every year. So meaning the numbers have gone up. Now, SRC having looked at that this is not sustainable. So they worked on a figure which was given to the ministry, and that was 70 for medical officers. Then for nursing students, they came to around 50,000, and also clinical officers, clinical medicine. This figure was not agreeable to the interns, and that's why they went on strike and ended up negotiating. They also went to court in Eldoret. And when they went to court, I think that has not been resolved.
Okay.
Because the matter, I think, is still in court. It's not been resolved. And therefore, even when you issue now another strike notice saying we will intend to go on strike, will the government be able to pay this much?
The government
That will
arranged
be
it in the
a
first
negotiation.
place. Yeah.
That will be a negotiation between the union and the government.
It was an agreement in the very beginning. So it's a matter of ability. Signed. Sealed.
That was a CPA.
In a CBA.
Yes.
In a CPA that was signed.
Yes.
And there is a case which is in court challenging whether CPAs lapse after what period.
Really?
Well, they come in batches of. We're in the current
Because
CPA.
the current CPA, the CPA that was negotiated at that time, it lapsed.
And
Why wasn't
one
it
could also
honoured?
say that within that time, even if it did lapse, the things that you were supposed to do within the term of that CBA was actually not done. Do we now say that because the time has lapsed, you didn't do what you're supposed to do?
And that is why
therefore
they have
people
gone to
suffer?
court
It must be honoured.
to seek I think they went to the Supreme Court to seek what is what the opinion,
But
the judicial opinion
Doctor.
as to whether CPA, whatever that had not been implemented at that time, can still be
You know,
implemented.
why would we
Because
wait?
that does not only affect the healthcare,
Yeah.
it affects our workers within the country.
This discussion is completely misplaced. WHO ratio of doctor to patient is around 1 to 1,000.
Yes.
The Kenyan one ranges, depending on who you are, 17,000, 15,000, 1 to 17,000, 1 to
yeah.
15,000. We have a clear shortage.
And it's a problem.
That is true.
And that is why we produce it. Even if we employed all these things, we would still have a shortage. Anyway, our time is
Our
up.
time is up.
Yeah.
So I will leave it there.
That's very good to continue with these conversations, but there are serious, deep-fissured issues that need to be discussed as we continue looking into this, and we welcome you to come again and do that with us as you continue the roles of oversight. Member of Parliament for Endebess constituency, as well as the chair of the Health Committee in the National Assembly, Dr. Robert Pukose has been our guest this hour. Thank you for being here this morning.
Thank you.
This is the Situation Room, the only way to start your day.